Lewis's Medical Surgical Nursing, 11th edition. Chapter 15, Cancer. Cancer is a group of diseases characterized by uncontrolled and unregulated growth of cells. The resulting problems may be directly related to the cancer, a consequence of treating the cancer, or a combination of both. The combined physiologic, psychologic, and social impact of cancer on patients and their caregivers is considerable. Despite advances in treatment and care, a great deal of anxiety and fear continue to be associated with a diagnosis of cancer. Educating healthcare professionals and the public is essential to promote realistic attitudes about cancer and cancer treatment. You are in a strategic position to lead efforts for changing attitudes about cancer. You can, 1, help people decrease their risk for cancer development, 2, increase rates of cancer screening, 3, help patients adhere to cancer management plans, and 4, support patients and caregivers as they cope with the effects of cancer and related treatment. You need to be knowledgeable about specific types of cancer, treatment options, management of side effects of therapy, and supportive therapies for cancer. Cancer is often considered a disease of aging, with most cases diagnosed in those over age 55 years. However, it occurs in people of all ages. An estimated 1.7 million people in the United States are diagnosed annually with invasive cancer, excluding basal and squamous cell skin cancers. Overall, both the incidence and mortality rates of cancer have been declining. The incidence of many cancers, such as colorectal, lung, breast, and oropharyngeal cancers, have declined largely because of preventative efforts. However, the incidence of other types of cancers, such as kidney, thyroid, pancreas, liver, uterus, skin melanoma, multiple myeloma, and non-Hodgkin's lymphoma, is increasing. Overall cancer incidence is higher in men than women. Gender differences in incidence and death rates for specific cancers are shown in the Gender Differences box and tables 15.1 and 15.2. Although mortality rates from all cancers combined are on the decline, it is still the second most common cause of death in the United States. Cancer is the leading cause of death of people 40 to 79 years of age. Each year, about 609,640 Americans are expected to die because of cancer, which is more than 1,600 people per day. Considerable progress has been made in controlling cancer for long periods. More than 15.5 million Americans are alive today who have a history of cancer. This includes those who have cancer and are undergoing treatment, are disease-free, or are in remission. Cancer survivors are discussed later on pages 264 and 265. Two major dysfunctions present in the process of cancer development: defective cell proliferation, growth, and defective cell differentiation. Defect in cell proliferation. Normally, most tissues have a population of undifferentiated cells known as stem cells. These stem cells ultimately differentiate and become mature, functioning cells of a specific tissue. Cell proliferation starts in the stem cell and begins when the stem cell enters the cell cycle, figure 15.1. The time from when a cell enters the cell cycle to when the cell divides into two identical cells is called the generation time of the cell. A mature cell continues to function until it degenerates and dies. All the body's cells are controlled by an intercellular mechanism that determines when cell proliferation is necessary. Under normal conditions, there's a state of dynamic equilibrium. This means cell proliferation equals cell degeneration or death. Normally, the process of cell division and proliferation is activated only in the presence of cell degeneration or death, apoptosis. Cell proliferation also occurs if the body has a physiologic need for more cells. For example, a normal increase in white blood cell WBC count occurs with infection. Another means of proliferation control in normal cells is contact inhibition. Normal cells respect the boundaries and territory of the cells surrounding them. They will not invade a territory that is not their own. We think the neighboring cells inhibit cell growth through the physical contact of the surrounding cell membranes. Cancer cells grown in tissue culture have a loss of contact inhibition. They have no regard for cell boundaries and grow on top of one another and on top of or between normal cells. The rate of normal cell proliferation from the time of cell birth to the time of cell death differs in each body tissue. In some tissues, such as bone marrow, hair follicles, and epithelial lining of the gastrointestinal GI tract, the rate of cell proliferation is rapid. In other tissues, such as myocardium and cartilage, cell proliferation does not occur or is slow. Cancer cells proliferate at the same rate as the normal cells of the tissue from which they arise. However, cancer cells respond differently from normal cells to the intracellular signals that regulate cell proliferation and death. The result is that the proliferation of the cancer cells is indiscriminate and continuous. Sometimes they produce more than 2 cells at the time of mitosis. In this way, there is continuous growth of a tumor mass, 1 times 2 times 4 times 8 times 16, and so on. This is termed the pyramid effect. The time needed for a tumor mass to double in size is known as its doubling size. Defect in cell differentiation. Cell differentiation is normally an orderly process that progresses from a state of immaturity to a state of maturity. Because all body cells are derived from the fertilized ova, all cells have the potential to perform all body functions. As cells differentiate, this potential is repressed, and the mature cell can perform only specific functions. With cell differentiation, there is a stable and orderly phasing out of cell potential. Under normal conditions, the differentiated cell is stable and will not de-differentiate or return to its previous undifferentiated state. Genetic link. Cancer involves the malfunction of genes that control differentiation and proliferation. 2 types of normal genes that can be affected by mutation are proto-oncogenes and tumor suppressor genes. Proto-oncogenes are normal cell genes that are important regulators of normal cell processes. Proto-oncogenes promote growth. Tumor suppressor genes suppress growth. Mutations that change the expression of proto-oncogenes can cause them to function as oncogenes, tumor-inducing genes. The proto-oncogene has been described as the genetic lock that keeps the cell in its mature functioning state. When this lock is unlocked, as may occur through exposure to carcinogens, agents that cause cancer, or oncogenic viruses, genetic alterations and mutations occur. The abilities and properties that the cell had in fetal development are again expressed. Oncogenes can change a normal cell to a malignant one. This cell regains a fetal appearance and function. For example, some cancer cells make new proteins characteristic of the embryonic and fetal periods of life. These proteins found on the cell membrane include carcinoembryonic antigen, CEA, and alpha fetoprotein, AFP. They can be found in the blood by laboratory studies. Other cancer cells, such as small cell cancer of the lung, make hormones that are usually made by cells arising from the same embryonic cells as the tumor cells. See complications of cancer later in this chapter on pages 260 to 263. Tumor suppressor genes regulate cell growth. They prevent cells from going through the cell cycle. Mutations can change tumor suppressor genes and make them inactive. This results in a loss of their tumor suppressing action. Examples of tumor suppressor genes are BRCA1 and BRCA2. Alterations in these genes increase a person's risk for breast and ovarian cancer. Another tumor suppressor gene is the APC gene. Mutations in this gene increase a person's risk for familial adenomatous polyposis, a precursor for colorectal cancer. See Chapter 42. Mutations in the p53 tumor suppressor gene have been found in many cancers, including bladder, breast, colorectal, esophageal, liver, lung, and ovarian cancers. Development of cancer. The following is a theoretical model of cancer development. The cause and development of each type of cancer are likely to be multifactorial. A common misbelief is that cancer development is a rapid, haphazard event. However, cancer is usually an orderly process that occurs over time. It has 3 stages: initiation, promotion, and progression. Figure 15.2. Initiation. Cancer cells arise from normal cells because of changes in genes. The first stage, initiation, involves a mutation in the cell's genetic structure. A mutation is any change in the usual DNA sequence. Genetic link. Gene mutations can occur in 2 ways: inherited from a parent, passed from one generation to the next, or acquired during a person's lifetime. Mutations are discussed in Chapter 12. The genetic predisposition to cancer is thought to play a role in about 5 to 10% of cancers. These genetic alterations lead to a high risk for developing a specific type of cancer. However, most cancers do not result from inherited genes. They are acquired from damage to genes occurring during one's lifetime. An acquired mutation is passed on to all cells that develop from that single cell. The damaged cell may die or repair itself. However, if cell death or repair does not occur before cell division, the cell will replicate into daughter cells, each with the same genetic alteration. Carcinogens. Many carcinogens, cancer-causing agents capable of producing cell alterations, are detoxified by protective enzymes and harmlessly excreted. If this protective mechanism fails, carcinogens can enter the cell's nucleus and alter deoxyribonucleic acid, DNA. Carcinogens may be chemical, radiation, or viral. Chemical carcinogens. Chemicals were identified as cancer-causing agents in the latter part of the 18th century. Percival Pott noted that chimney sweeps had a higher incidence of cancer of the scrotum associated with exposure to soot residue in chimneys. As the years passed, we have found many chemicals that are carcinogens, e.g. benzene, arsenic, formaldehyde. People exposed to these chemicals over time have a greater incidence of certain cancers than others. The long latency period from the time of exposure to the development of cancer makes it hard to identify cancer-causing chemicals. Radiation. Radiation can cause cancer in almost any body tissue. When cells are exposed to a source of radiation, damage occurs to DNA. Certain cancers are correlated with radiation as a carcinogenic agent. The incidence of leukemia, lymphoma, and thyroid cancer increased in the general population of Hiroshima and Nagasaki after the atomic bomb explosions. A higher incidence of bone cancer occurs in people exposed to radiation in certain occupations, such as radiologists, radiation chemists, and uranium miners. Ultraviolet UV radiation has long been associated with melanoma and squamous and basal cell skin cancers. Skin cancer is the most common type of cancer among whites in the United States. Sunlight exposure is the main source of UV exposure, giving off UVA and UVB rays. UV radiation from tanning beds also causes skin cancer. Viral carcinogens. Certain DNA and ribonucleic acid, RNA, viruses, termed oncogenic, can alter the cells they infect and induce malignant transformation. These viruses have been identified as causative agents of cancer in animals and humans. Burkitt's lymphoma is associated with Epstein-Barr virus, EBV. People with acquired immunodeficiency syndrome, AIDS, which is caused by human immunodeficiency virus, HIV, have a high incidence of Kaposi sarcoma, see Chapter 14. Other viruses linked to cancer development include hepatitis B virus, which is associated with hepatocellular cancer, and human papillomavirus, HPV. HPV is thought to cause lesions that progress to squamous cell cancers, such as cervical, anal, and head and neck cancers. Promotion. A single alteration of the genetic structure of the cell is not enough to cause cancer. However, the odds of cancer development are increased with the presence of promoting agents. Promotion, the second stage in cancer development, is characterized by the reversible proliferation of the altered cells. An increase in the altered cell population further increases the likelihood of more mutations. An important distinction between initiation and promotion is that the activity of promoters is reversible. This is a key concept in cancer prevention. Promoting factors include agents such as dietary fat, obesity, cigarette smoking, and alcohol use. Changing a person's lifestyle to modify these risk factors can reduce the chance of cancer development. Around 1/3 of cancer-related deaths in the United States are related to tobacco use, unhealthy diet, physical inactivity, and obesity. Several promoting agents have activity against specific types of body tissues. So these agents tend to promote specific kinds of cancer. For example, cigarette smoke is a promoting agent in lung cancer. In conjunction with alcohol use, it promotes esophageal and bladder cancers. Some carcinogens, termed complete carcinogens, are capable of both initiating and promoting cancer development. Cigarette smoke is an example of a complete carcinogen. A period of time elapses between the first genetic alteration and the actual clinical evidence of cancer. This period, called the latent period, includes both the initiation and promotion stages in the natural history of cancer. The variation in the length of time that elapses before the cancer becomes clinically evident is related to the mitotic rate of the tissue of origin and environmental factors. In most cancers, this process is years or even decades in length. For the disease process to become clinically evident, the cells must reach a critical mass. A tumor that is 1.0 centimeters, 0.4 inch, the size usually detectable by palpation, has a billion cancer cells. A 0.5 centimeter tumor is the smallest that can be detected by current diagnostic measures, such as MRI. Progression. Progression is the last stage in the natural history of a cancer. This stage is characterized by increased growth rate of the tumor, increased invasiveness, and metastasis, spread of the cancer to a distant site. Certain cancers have an affinity for particular tissue or organ as a site of metastasis, e.g., colon cancer often spreads to the liver. Other cancers, e.g., melanoma, are unpredictable in their pattern of metastasis. The most common sites of metastasis are lungs, liver, bone, brain, and adrenal glands, figure 15.3. Metastasis is a multi-step process. It begins with the rapid growth of the primary tumor, figure 15.4. As the tumor increases in size, developing its own blood supply is critical to its survival and growth. The process of the formation of blood vessels within the tumor itself is termed tumor angiogenesis. It is facilitated by tumor angiogenesis factors made by the cancer cells. Tumor cells can detach from the primary tumor, invade the tissue surrounding the tumor, and penetrate the walls of lymph or vascular vessels for metastasis to a distant site. Once free from the primary tumor, metastatic tumor cells often travel to distant organ sites by hematogenous or lymphatic routes. Hematogenous metastasis involves several steps beginning with primary tumor cells penetrating blood vessels. These tumor cells then enter the circulation, travel through the body, and adhere to and penetrate small blood vessels of distant organs. Most tumor cells do not survive this process and are destroyed by mechanical mechanisms, e.g., turbulence of blood flow, and cells of the immune system. The formation of a combination of tumor cells, platelets, and fibrin deposits may protect some tumor cells from destruction in blood vessels. In the lymphatic system, tumor cells may be trapped in the first lymph node confronted and likely to spread from a tumor. This lymph node is referred to as the sentinel lymph node. A sentinel lymph node biopsy, SLNB, can be done to help determine the extent of the cancer. A positive SLNB means cancer is present in the sentinel node and may have spread to other lymph nodes and organs. Sometimes, the tumor cells may bypass local lymph nodes and travel to distant lymph nodes, a phenomenon termed skip metastasis. Tumor cells that survive the process of metastasis must create an environment in the distant organ site that promotes their growth and development. Growth and development are facilitated by the tumor cell's ability to evade cells of the immune system and produce a vascular supply within the metastatic site, like that of the primary tumor site. Vascularization is critical to the supply of nutrients to the metastatic tumor and the removal of waste products. Role of the immune system. This section is limited to a discussion of the role of the immune system in the recognition and destruction of tumor cells. For a detailed discussion of immune system function, see Chapter 13. The immune system has the potential to tell normal, self, cells from abnormal, non-self, cells. For example, cells of transplanted organs can be recognized by the immune system as non-self and thus elicit an immune response. This response can result in organ rejection. Similarly, cancer cells can be perceived as non-self. This can elicit an immune response, resulting in their rejection and destruction. However, unlike transplanted cells, cancer cells arise from normal human cells, and although they are mutated and thus different, the immune response that is mounted against cancer cells may be inadequate to effectively kill them. Cancer cells may have altered self-surface antigens because of malignant transformation. These antigens are termed tumor-associated antigens, TAAs, figure 15.5. We think that the immune system responds to TAAs through a process termed immunologic surveillance. In this process, lymphocytes continuously check cell surface antigens. They detect and destroy cells with abnormal or altered antigenic determinants. Under most circumstances, immune surveillance prevents transformed cells from developing into clinically detectable tumors. Immune response to cancer cells involves cytotoxic T cells, natural killer NK cells, macrophages, and B cells. Cytotoxic T cells play a dominant role in resisting tumor growth. These cells can kill tumor cells. T cells are important in the production of cytokines, e.g. interleukin-2, IL-2, and Y interferon, which stimulate T cells, NK cells, B cells, and macrophages. NK cells can directly lyse tumor cells spontaneously without any prior sensitization. Y interferon, made by T cells, and IL-2, released from T cells, stimulate NK cells, resulting in increased cytotoxic activity. Monocytes and macrophages have several important roles in tumor immunity. Y interferon can activate macrophages to become nonspecifically lytic for tumor cells. Macrophages secrete cytokines, including IL-1, tumor necrosis factor, TNF, and colony-stimulating factors, CSFs. The release of IL-1, coupled with the presentation of the processed antigen, stimulates T-cell activation and production. Alpha interferon augments the killing ability of natural killer cells. TNF causes hemorrhagic necrosis of tumors and exerts cytocidal or cytostatic actions against tumor cells. CSFs regulate the production of various blood cells in the bone marrow and stimulate the function of various WBCs. B cells can make specific antibodies that bind to tumor cells. These antibodies are often detectable in the patient's serum and saliva. Escape mechanisms from immunologic surveillance. The process by which cancer cells evade the immune system is termed immunologic escape. Possible mechanisms by which cancer cells escape immunologic surveillance include 1. suppression of factors that stimulate T cells to react to cancer cells. 2, weak surface antigens, allowing cancer cells to sneak through immunologic surveillance. 3, development of tolerance of the immune system to some tumor antigens. 4, suppression of the immune response by products secreted by cancer cells. 5, induction of suppressor T cells by the tumor. And 6, blocking antibodies that bind TAAs, thus preventing their recognition by T cells. Figure 15.6. Oncofetal antigens and tumor markers. Oncofetal antigens are a type of tumor antigen. They are found on the surfaces and the inside of cancer cells and fetal cells. These antigens are an expression of the shift of cancerous cells to a more immature metabolic pathway. This expression is usually associated with embryonic or fetal periods of life. The reappearance of fetal antigens in cancer is not well understood. We think it is the result of the cell regaining its embryonic capability to differentiate into many different types of cells. Examples of oncofetal antigens are CEA and AFP. CEA is found on the surface of cancer cells from the GI tract and normal cells from the fetal gut, liver, and pancreas. Normally, CEA disappears during the last 3 months of fetal life. CEA was originally isolated from colorectal cancer cells. However, high CEA levels can be found in non-malignant conditions, e.g. cirrhosis of the liver, ulcerative colitis, heavy smoking. Oncofetal antigens can be used as tumor markers that may be clinically useful to monitor the effect of therapy and indicate tumor recurrence. However, they are not 100% specific for tumor recurrence. Tumor markers are affected by various factors that must be accounted for when reviewing these results. For example, the persistence of high preoperative CEA titers after surgery means that the tumor is not completely removed. A rise in CEA levels after chemotherapy may mean recurrence or spread of the cancer, or it may be due to chronic lung disease and smoking. AFP is made by malignant liver cells and fetal liver cells. AFP has diagnostic value in primary liver cancer, hepatocellular cancer. It is also made when metastatic liver growth occurs. This makes AFP valuable in tumor detection and determination of tumor progression. AFP levels are also high in some cases of testicular cancer and viral hepatitis. Other examples of oncofetal antigens are CA125, ovarian cancer, CA19-9, pancreatic and gallbladder cancer, prostate-specific antigen, PSA, prostate cancer, and CA15.3 and CA2729, breast cancer. Molecular markers for specific tumors include KRAS, expression of oncogene in colon cancer, epidermal growth factor receptor, EGFR, often overexpressed in lung cancer, and human epidermal growth factor receptor 2, HER-2, expression in breast cancer. Benign versus malignant neoplasms. Tumors can be classified as benign or malignant. In general, benign neoplasms are well differentiated. Malignant neoplasms range from well differentiated to undifferentiated. The ability of malignant tumor cells to invade and metastasize is the major difference between benign and malignant neoplasms. Other differences are outlined in Table 15.3. Classification of cancer. Tumors can be classified according to anatomic site, histology, grading, and extent of disease, staging. Tumor classification systems provide a standardized way to, 1, communicate the status of the cancer to all members of the interprofessional care team, 2. Assist in determining the most effective treatment plan. 3. Evaluate the treatment plan. 4. Predict prognosis. And 5. Compare groups for statistical purposes. Anatomic site classification. In the anatomic classification of tumors, the tumor is identified by the tissue of origin, anatomic site, and behavior of the tumor, e.g. benign or malignant. Table 15.4. Carcinomas originate from embryonal ectoderm, skin and glands, and endoderm, mucous membrane linings of the respiratory tract, GI tract, and genitourinary GU tract. Sarcomas originate from embryonal mesoderm, connective tissue, muscle, bone, and fat. Lymphomas and leukemias originate from the hematopoietic system. Histologic classification. In histologic grading of tumors, the appearance of cells and degree of differentiation are evaluated pathologically. For many tumor types, 4 grades are used to evaluate abnormal cells based on the degree to which the cells resemble the tissue of origin. Tumors that are poorly differentiated, undifferentiated, have a poorer prognosis than those that are closer in appearance to the normal tissue of origin, well differentiated. Grade 1, cells differ slightly from normal cells, mild dysplasia, and are well differentiated, low grade. Grade 2, cells are more abnormal, moderate dysplasia, and moderately differentiated, intermediate grade. Grade 3, cells are very abnormal, severe dysplasia, and poorly differentiated, high grade. Grade 4, cells are immature, primitive, anaplasia, and undifferentiated. Cell of origin is hard to determine, high grade. Grade X, grade cannot be assessed. Extent of disease classification. Classifying the extent and spread of disease is termed staging. Staging is based on the anatomic extent of disease. Although there are similarities in the staging of various cancers, there are many differences for specific types of cancer. Clinical staging. The clinical staging classification system determines the anatomic extent of the malignant disease process by stages. Stage 0, cancer in situ. Stage 1, tumor limited to the tissue of origin, localized tumor growth. Stage 2, limited local spread. Stage 3, extensive local and regional spread. Stage 4, metastasis. Clinical staging has been used as a basis for staging a variety of tumor types, including colorectal cancer, see Figure 42.7, and Hodgkin's lymphoma, see Figure 30.15. Other cancers, e.g. leukemia, do not use this staging approach. TNM classification system. The TNM classification system, Table 15.5, is used to determine the anatomic extent of the disease involvement according to 3 parameters: tumor size and invasiveness, T, presence or absence of regional spread to the lymph nodes, N, and metastasis to distant organ sites, M. Examples of the TNM classification system can be found in tables 27.17 and 51.6. TNM staging cannot be applied to all cancers. For example, leukemias are not solid tumors and cannot be staged using these guidelines. The latest cancer staging guidelines for some cancers add non-anatomic factors when making the final determination of stage. Staging is still based on the TNM classification, but it now adds grade and hormone receptor expression. When appropriate, it also includes genomic profile results, e.g. Oncotype DX mammoprint. This information should allow a more accurate determination of prognosis and better guide therapy. Carcinoma in situ, CIS, refers to a cancer whose cells are localized and show no tendency to invade or metastasize to other tissues. CIS has its own designation in the system, and it looks like a big T with a small IS under it there. Because it has all the histologic characteristics of cancer except invasion. a key feature of the TNM Staging System. Staging of the disease can be done initially and at several points. Clinical staging is done at the completion of the diagnostic workup to guide treatment selection. Examples of diagnostic studies that may be done to assess for extent of disease include bone and liver scans, ultrasonography, and CT, MRI, and positron emission tomography (PET) scans. Surgical staging refers to the extent of the disease as determined by surgical excision, exploration, and/or lymph node sampling. For example, a laparotomy and splenectomy may be done to stage Hodgkin's lymphoma. During a staging laparotomy, lymph node biopsies may be done, and margins of any masses may be marked with metal clips for use during radiation therapy. Exploratory surgical staging is being used less often as non-invasive diagnostic technology becomes more sophisticated. After the extent of the disease is determined, the stage classification is set. The original description of the extent of the tumor stays part of the record. If more treatment is needed or if treatment fails, retreatment staging is done to determine the extent of the disease before retreatment. Restaging classification, RTNM, is differentiated from the stage at diagnosis, since the clinical significance may be different. Staging can never decrease, but the stage can increase. For example, a patient may initially be a stage 3. After treatment failure, the tumor metastasizes, and now the patient is a stage 4. In addition to tumor classification systems, other rating scales can be used to describe and document the status of patients with cancer at the time of diagnosis, treatment and retreatment, and at each follow-up examination. For example, the Karnofsky Performance Scale and Katz Index of Independence in Activities of Daily Living describe patients' functional performance. Prevention and early detection of cancer. We can reduce the incidence of cancer through a stronger emphasis on prevention through promoting healthy lifestyles. As a nurse, you have an essential role in the prevention and early detection of cancer. Reducing risk factors reduces the incidence of cancer. For example, rates of smoking-related cancers, e.g. lung and head and neck cancers, have declined with a reduction in smoking rates. Early detection and prompt treatment are responsible for increased survival rates in patients with cancer. Colonoscopy is important in reducing colon cancer mortality, both by early detection of colon cancers and prevention, e.g. excision of adenomatous polyps. The goals of public education are to 1. Motivate people to recognize and change behaviors that may negatively affect health, and 2. Encourage awareness of and participation in health-promoting behaviors. When you teach about cancer, try to minimize the fear that surrounds the diagnosis. Teach people to be familiar with their bodies. Review how to perform self-examinations and the 7 warning signs of cancer, Table 15.6. Encourage them to seek immediate medical care if they notice a change in what is normal for them or if cancer is suspected. Following recommended cancer screening guidelines for breast, colon, cervical, and prostate cancer from the American Cancer Society, ACS, is important. Diagnosis of cancer. When a patient has a possible diagnosis of cancer, it is a stressful time for the patient and caregivers. Patients may undergo several days to weeks of diagnostic studies. During this time, fear of the unknown may be more stressful than the actual diagnosis of cancer. Patients may be overwhelmed or confused by the need for multiple diagnostic studies and consultations. Help coordinate care between multiple specialists. Explain the purpose of required tests and any special preparation needed for them. Some facilities have comprehensive oncology teams and services that are all housed in the same building to help coordinate care among the cancer specialists. These centers combine appointments to make the experience convenient and comfortable for patients and their caregivers. While patients are waiting for the results of diagnostic studies, be available to actively listen to their concerns. Their anxiety may arise from myths and misconceptions about cancer, e.g., cancer is a death sentence. Cancer treatment is worse than the illness. Correcting these misconceptions can help to minimize their anxiety. Learn to recognize your own discomfort during difficult conversations. Avoid communication patterns that may hinder exploration of feelings and meaning. These include providing false reassurances, e.g., it's probably nothing, redirecting the discussion, e.g., let's discuss that later, generalizing, e.g., everyone feels this way, and using overly technical language. These self-protective strategies deny patients the opportunity to share the meaning of their experience. They can jeopardize your ability to build a trusting relationship with your patients. During this time of high anxiety, the patient may need repeated explanations of the diagnostic workup. Include as much information as needed by the patient and caregivers. Give clear, understandable explanations and reinforce them as needed. Written information is helpful to reinforce verbal information. A diagnostic plan for the person suspected of having cancer includes the health history, including a history of present illness, identifying risk factors, the physical examination, and specific diagnostic studies. For many people, cancer is diagnosed after the findings of an abnormal screening test, e.g., mass on mammogram. For others, they are alerted to the presence of cancer by a presenting symptom or cluster of symptoms, e.g., cough and hemoptysis, anorexia, and weight loss. Hemoptysis is coughing up blood. Concentrate on risk factors for cancer. Obtain information about any family and personal history of cancer and any exposure to or use of known carcinogens, e.g., cigarette smoking, occupational pollutants or chemicals, radiation exposure. Review the medical history for diseases characterized by chronic inflammation or immunosuppression, e.g. ulcerative colitis, and treatments, e.g. hormone therapy, previous anti-cancer therapies. Assess factors that may call for additional supportive care during therapy, including alcohol or drug use, living situation, social support, and coping strategies for perceived stressors. Diagnostic studies depend on the suspected primary or metastatic sites of the cancer. Specific procedures as they relate to each body system are discussed in the respective assessment chapters. Examples of diagnostic studies include cytology studies, e.g. pap test, bronchial washings, tissue biopsy, chest x-ray, complete blood count, CBC, chemistry profile, liver function studies, e.g. aspartate aminotransferase, AST, endoscopic examination, upper GI, sigmoidoscopy, or colonoscopy, including YAC tests for occult blood. Radiographic studies, e.g. mammography, ultrasound, CT scan, MRI, radioisotope scans, e.g. bone, lung, liver, brain, PET scan, figure 15.7, tumor markers, e.g. CEA, AFP, PSA, CA125, genetic markers, e.g. BRCA1, BRCA2, molecular receptor status, e.g. estrogen and progesterone receptors, bone marrow examination, if a hematolymphoid malignancy is suspected, or to document metastatic disease. Biopsy. A biopsy is the removal of a tissue sample for pathologic analysis. Various methods are used to obtain a biopsy, depending on the location and size of the suspected tumor. Percutaneous biopsy is often done for tissue that can be safely reached through the skin. Endoscopic biopsy may be used for lung or other intraluminal lesions, esophageal, colon, bladder. When a tumor is not easily accessible, a surgical procedure, laparotomy, thoracotomy, craniotomy, is often needed to obtain a piece of the tumor tissue. Many radiographic techniques may be used in conjunction with the biopsy procedure, e.g. CT, MRI, ultrasound-guided biopsy, stereotactic biopsy. to improve tissue localization. Various types and sizes of biopsy needles are available and chosen according to the type of tissue to be sampled. Fine needle aspiration, FNA, may be done with a small gauge aspiration needle that provides cells from the mass for cytologic examination. Large core biopsy cutting needles deliver an actual piece of tissue, core, that can be analyzed. An advantage is that it preserves the histologic architecture of the tissue specimen. Excisional biopsy involves the surgical removal of the entire lesion, lymph node, nodule, or mass, so it is therapeutic as well as diagnostic. If an excisional biopsy is not feasible, an incisional biopsy, partial excision, may be done with a scalpel or dermal punch. Pathologic evaluation of a tissue sample is the only definitive way to diagnose cancer. The pathologist examines the tissue to determine 1. Whether it is benign or malignant, 2. The anatomic tissue from which the tumor arises, histology, and 3. The degree of cell differentiation, histologic grade. Other information that can be obtained includes the extent of malignant involvement, size of tumor and depth, evidence of invasiveness, extracapsular or lymphatic, adequacy of surgical excision, positive or negative surgical margin status, and nuclear grade, mitotic rate. Special staining techniques may give insight into responsiveness of the tumor to treatment or disease behavior, receptor status, tumor markers. Interprofessional care. Treatment goals. The goals of cancer treatment are cure, control, and palliation, figure 15.8. When caring for the patient with cancer, knowing the treatment goals will help you appropriately communicate with, teach, and support the patient. The main factors that determine what therapy is used are the tumor histology and staging outcomes. Other crucial factors are the patient's physiologic status, e.g. presence of comorbid illnesses, psychologic status, and personal desires, e.g. active treatment versus palliation. These factors influence 1. The modalities chosen for treatment, e.g. surgery, radiation therapy, chemotherapy, immunotherapy, targeted therapy, hormone therapy. 2. How therapies are sequenced. And 3. The length of time the treatment is prescribed. Each type of therapy can be used alone or in any combination during initial treatment, as maintenance therapy and in retreatment if the disease does not respond or recurs after remission. For many cancers, 2 or more of the treatment modalities, known as multimodality therapy or combined modality therapy, are used to achieve the goal of cure or control for a long time. Multimodality therapy has the benefit of being more effective because it takes advantage of more than one mechanism of action, but often at the expense of greater toxicity. Cure. When cure is the goal, treatment is expected to have the greatest chance of eradicating the cancer. Curative cancer therapy differs according to the cancer being treated. It may involve local therapies, e.g. surgery or radiation, alone or in combination with or without periods of adjunctive systemic therapy, e.g. chemotherapy. For example, basal cell skin cancer is usually cured by surgical removal of the lesion and several weeks of radiation therapy. In the treatment plan for acute promyelocytic leukemia, which has curative potential, several chemotherapy drugs are given on a scheduled basis over many months to several years. Testicular cancer can be cured with a combination of surgery, chemotherapy, and radiation. There's no benchmark that ensures cure for most cancers. In general, the risk for recurrent disease is highest after treatment completion. It gradually decreases the longer the patient is disease-free after treatment. Cancers with a higher mitotic rate, e.g. testicular cancer, are more likely to recur than cancers with slower mitotic rates, e.g. postmenopausal breast cancer. so the time frame to consider a person cured may differ according to the tumor and its characteristics. Control. Control is the goal of treatment for cancers that cannot be completely eradicated, but are responsive to anti-cancer therapies. As with other chronic illnesses, e.g. diabetes, heart failure, cancer can be controlled for long periods with therapy. Examples include multiple myeloma and chronic lymphocytic leukemia. See Chapter 30. Patients may undergo an initial course of treatment followed by maintenance therapy for as long as the disease is responding. Patients are monitored closely for early signs and symptoms of disease recurrence or progression and the cumulative effect of therapy. Evidence of tumor resistance, e.g. disease progression, may call for changing to a different therapy. Palliation. Palliation is the goal of treatment when the goals are the relief of or control of symptoms and maintaining a satisfactory quality of life. Palliative care and treatment are not mutually exclusive and can take place concurrently. An example of treatment in which palliation is the goal includes using radiation therapy to reduce tumor size and relieve subsequent symptoms, like the pain of bone metastasis. Personalized cancer medicine. Personalized medicine is an emerging trend in cancer treatment. It involves using the patient's genetic information to guide decisions about prevention, diagnosis, and treatment of cancer. Many diagnostic studies, tumor markers, genetic markers, molecular receptor status, are useful in determining treatment options. Before personalized medicine, most patients with a specific type and stage of cancer received the same treatment. However, some treatments worked well for some patients and not as well for others. With increasing research, we have found the genetic differences in people and their tumors explain many of these different responses to treatment. By performing genetic tests and analysis, treatments can now be personalized. Next-generation sequencing, also known as massive parallel sequencing, can sequence millions of DNA fragments. This technology can determine if a patient's cancer is caused by a hereditary cancer syndrome or if it is sporadic. Results guide which specific drugs target a patient's mutation and help identify clinical trials specific to the genetic mutation. Targeted therapy, Table 15.3, targets a cancer's specific genes or proteins that contribute to cancer growth and survival. Treatment with a targeted therapy depends on assessing whether the tumor has the specific target. This is usually done by testing a sample of the tumor obtained through a biopsy. Pharmacogenomics and pharmacogenetics is a study of genomic variation associated with drug responses. Examples of how the results of genetic testing can be applied to the use of cancer drugs are shown in Table 12.5. For example, vemurafenib, Zelboraf, is used to treat patients with metastatic melanoma. However, it is indicated only for the treatment of patients with melanoma whose tumors express a gene mutation called BRAF V600E. Despite the promises of personalized cancer treatments, not all types of cancers have personalized treatment options. Genetic testing may be costly and time-consuming. Many insurance plans do not cover the costs of these tests. Some personalized treatments, such as targeted treatments, can be expensive.